objectives. Let us begin with the case scenario. So there is one case, say a 25-year-old, he has been shifted from a local hospital with a, say, history of a left limb cellulitis. There is a local tenderness, warmth, and patient is, the leg is erythematous. His vitals appears to be, say, around heart rate is around 90, BP is around 80-50, the respiratory rate is around 17 to 20, and he is maintaining saturation in the room air with a GRBS of 160, and he is afebrile. But he is conscious, but he is not able to give a proper history or communicate properly. So what do you want to label him? If you want to, since the topic is based on the sepsis, so how many of you want to label it as just a SIRS syndrome, sepsis, septic shock, severe sepsis? Anybody? Okay, how many of you practice critical care? Only one hand, half hand. Okay, fine. So the main recommendation is you have to identify the category of the sepsis. That is the modification which has been changed. So before 2001 till 2021, so we used to follow so many guidelines, right from the SIRS, severe sepsis. There were a lot of definitions like sepsis, severe sepsis, and again septic shock. But right now what we have is only two categories. Either the patient is having sepsis or the patient is having septic shock. So then what is the sepsis? Definition of the sepsis. Sepsis is nothing but a life-threatening organ dysfunction which is caused by a dysregulated host response to an infection. Then what is septic shock? Septic shock is nothing but the subset of a sepsis in which underlying circulatory, cellular, and metabolic abnormalities, they contribute to a greater risk of mortality than that posed by sepsis alone. So these recommendations have been modified over a time. The latest what I could get is, one is from 2021, again modified in 22, and the latest one is 2023. So what they have done is basically they have combined the 6R and a 3R bundle, septic treatment bundles, sepsis care bundles. They clubbed together and they revised and created a single 1R bundle. The whole idea is to give all the possible treatment care as early as possible so that the recovery, microcirculation, everything will be in a better. So this essentially involves 5 steps. We'll try to see one by one. So in this one, they have given a recommendation for the screening and the early treatment. So what they have recommended is each center should have a performance improvement program which should include sepsis screening for acutely ill, high-risk patients, and there has to be SOPs for treating the same. They advise against using a single screening tool like a SOFA scoring. They advise you to take 2 or more screening tools like a NEWS or a MUSE. Then you combine together, decide whether the patient is having sepsis or a septic shock. Suppose if you want to just label a sepsis, the SOFA scoring is more than sufficient. If the SOFA scoring is more than 2, yes, your diagnosis of a sepsis is confirmed. But if you want to label it as a septic shock, the patient should have hypotension with, patient is having hypotension and he is not maintaining without any vasopressor support with serum lactate more than 2 millimoles per liter. So once you identify the patient is having sepsis or a septic shock, so what is the first line of your management? First thing is take a blood culture. Suppose the patient is already labeled as a septic shock, give the antibiotic within first hour. Suppose if I have identified it is only the sepsis, try to give the antibiotics empirical best possible within 3 hours of the identification. And whenever you are choosing antimicrobials, so empirical antimicrobials, you try to choose drugs which has got a broad spectrum, which can cover both gram positive and gram negative, keeping in mind that patient might have a multi-drug resistance organism including MRSA. Try to give a bolus dose, full dose. Do not worry about the hepatorenal functionality. You give a full dose, achieve a baseline, achieve a level. Then based on the hepatorenal functionality, you try to titrate your doses. There are few recommendations for the use of biomarkers, especially the using of the procalcitonin. So it is now recommended that one should not use both procalcitonin as well as the clinical evaluation to start the antibiotics. Suppose if you think clinically the patient is having infection, sepsis or a septic shock, you start the antibiotic. Then why one should take a baseline procalcitonin levels? So this comes in a picture when you are de-escalating your antibiotics. For example, you take a baseline procalcitonin levels. After 5 days, you take one more levels of the procalcitonin. You try to compare from the baseline to the latest one. Suppose it has been decreased more than 80 to 90% of percentage, then it is a time to stop the antibiotic. That means the infection is coming down. So that is the recommendation. Otherwise, if you have already given 7 full days of the antibiotic course, you can very well stop the antibiotics. Then coming to the second recommendation is you resuscitate the patient with a fluid. So this is basically based on the two concepts. That is, one is fluid tolerance and a fluid responsiveness. So this is basically based on the glycocalyx resuscitation, where the fluid tolerance is nothing but to which the patient can tolerate the administration of the fluids without developing any organ dysfunction, where fluid responsiveness is defined as the increase in the stroke volume at least by 10% whenever you give a bolus fluid. Then previous recommendation, how many of you are giving say around 20 to 30 ml per kg body weight fluid? Still somebody is using, or increased, decreased? So nowadays, so previously the recommendation before 2021 and 22, so it was recommended that you load the patient with the fluid up to 30 ml per kg body weight within 3 years. But nowadays the recommendation is gone. So what they are recommending is give a small allocates of fluid, say around 100, 200, up to 500, and try to monitor the hemodynamics, how the patient is responding. Based on that one, you go ahead whether to give the fluid or start something else. So the main take point is, so you have to look for the restoration of the microcirculation. And when we are talking about the monitoring of the fluids, it is always recommended that you try to monitor the dynamic parameters like stroke volume, IVC, or a pulse pressure variation, or passive leg raise. Suppose you have a setup in which the ultrasound is not there, intra-arterial pressure you cannot measure, so all the pulse pressure, the IVC you cannot measure, stroke volume you cannot measure. So don't worry, in that cases you try to elicit the response for your passive leg raise. If it is more than 15%, they are the fluid responders. So static these parameters, it is no. Then coming to the choice of the fluids. So previously it was recommended that either you can use a balanced or a chloride rich solution. But nowadays it is recommended that you have to use a balanced crystalloid solutions. The reason, they are more closer to the plasma, electrolyte composition is more closer to that of a plasma. And if you are giving a chloride rich solutions, there are possibilities of hyperchloremic acidosis, especially if you are giving a more volume. So there are chances of cytokine secretion, renal vasoconstriction, and a renal failure also. Then previously there were a debate that you can either use a colloid or a albumin whenever the case is, patient is suitable. But nowadays it is strict no, and it is not preferred. Evidence is not recommending. There are some recommendations updated for the serum lactate also. So we all know that it is nothing but the anaerobic metabolism glycolysis, which can be elevated in many cases, clinical condition, right from the stress to the infection also. And there is a positive association between the high lactate levels and the mortality has been proven. So what they recommend is you take a baseline serum lactate level, you start resuscitating the patient. Again after 2 to 4 hours, you again once again you measure the serum lactate level. Look whether the lactate levels are decreasing or it is remaining the same level. If it is remaining in the same level, you need to be more aggressive. You have to go ahead with something else. Suppose if it is coming down, your resuscitation is good, patient is responding. But there are some setups where serum lactates will not be available. So don't worry, in that cases, the recommendation gives that look for the capillary refills. If it is less than 2 seconds, worst cases also 2 to 3 seconds also, it can be taken as a normal and it can be monitored. If you remember the case I have given, so the BP was around 80-50. So the fluid was given, but still the BP you have given for say half an hour, 45 minutes, 1 hour you are waiting. The BP is still at the 70-40 only. There is no improvement. What you will do? You want to give more fluid or something else? Vasopressor you want to consider? So yes. So the recent recommendation says that the vasopressors to be started along with the fluid resuscitation. Do not wait till the fluid is given, then start the vasopressor. You can start simultaneously both vasopressor and the fluid resuscitation simultaneously. Remember, try to target your mean arterial pressure at 60 or 65 only. Do not try to target more than 65. And in an elderly patient, if the age is more than 65, it is recommended you can keep a little bit of a hypotension, permissive hypotension with a mean arterial pressure 60 to 65. Okay, so here the noradrenaline is the obvious drug of choice, and please do not wait to start the noradrenaline only after securing the central line we are going to start. No, whenever the peripheral line is there, you start the noradrenaline. Simultaneously, you try to take the central line and switch it over. Okay, I have started the noradrenaline. Initially, I have given the fluid, but still the BP is not picking up. So my noradrenaline is going somewhere around 0.25 to 0.5 microgram per kg per minute. So what should I do now? Shall I increase the dose of the noradrenaline or shall I do something else? So here we are supposed to go for the second line of the vasopressor, that is vasopressing. So whenever you have started the noradrenaline and the dose is going at a 0.25 to 0.5 microgram per kg per minute and there is no response, yes, you can go ahead and start with the vasopressin. Added advantage is it can prevent the side effect posed by your noradrenaline by the that is the adrenergic action. That overload can be prevented. Still, if you think that the microcirculation is not improving, hypoperfusion is persisting, so you can either go ahead and start the dobutamine or switch to adrenaline itself. And remember, whenever you are starting 2 or more vasopressors or a combination of a vasopressor and inotropes, always try to monitor with the invasive blood pressure monitor. There are some other recommendations which are updated, even though the supporting data are not very conclusive. So one of them is hydrocortisone. So we all know that the steroids will try to counter the inflammatory state, which is the mainstay of your sepsis and a septic shock, especially septic shock. So they recommend to start the steroids whenever you start the noradrenaline for more than 4 hours with a dose of say more than 0.25 microgram per kg, and there is no response, you can give a dose of a steroid. So it can be given as a bolus in a divided dose or an infusion also. There are some takes on the soda bicarbonate. We, being an anesthesiologist, basically we all love soda bicarbonate. We want to give a soda bicarbonate. So we all know that whenever there is a acidosis, the heart will not contract properly. The receptors becomes desensitized, so the response will not be adequate. So whenever there is a acidosis is there, bicarbs levels are less than 5 and a pH is 7.1, then it is recommended to give a soda bicarb. Otherwise, just mere pH is 7.1, 7.1, 7.2, it is not an indication until unless the patient is having a renal failure. There is, this is last slide, there are some recommendations which have been downgraded from what they have proposed strongly. So use of the proton pumps. So they advise to give proton pumps inhibitors to all the patients, but there is no benefit versus risk. They compared, they have not found any added advantage. but still we end up giving the proton pump inhibitors, considering that they are inexpensive and easily available, and which help us to prevent the stress ulcers. To summarize, the septic care bundles, that 3 hours and 6 hours have been combined, and they have combined to a 1 hour bundle only. And this 1 hour bundle has got the 5 steps, and the first one is they have removed the use of the single scoring system. The advice is to use 2 or more scoring systems, and they emphasize to measure the serum lactates every 2 to 4 hours. And where the setups are unable to get the serum lactate levels, go ahead and try to measure the capillary filling, to assess the tissue perfusion, and take the blood culture and try to give a broad spectrum antibiotics covering all the MDR, including the MRSA. And regarding the fluid, try to give a repeated bolus fluids, and try to give a balanced salt. And for a vasopressors, noradrenaline is the drug of choice. Try to give a vasopressor along with the IV fluids, and try to maintain the mean arterial pressure somewhere around 65. Do not try to target more than that. Thank you.
Thank you, Dr. Prashanth. It was